we're going to have our panelists, Anu, introduce themselves.
Yeah, it would be nice for our panelists to just describe take a couple minutes to describe your journey, your personal and professional journey, and kind of talking more innovation and gender and how you faced what you faced in your profession. Amy, do you want to start?
Yeah, I can start first. It's nice to be here and listen to these fantastic presentations. Dr. Parangi and I come from the same institution, and yet the way she puts together the same data I've seen before just makes it all have a story that needs to be continued. So I really appreciate that. I direct cardiology, outpatient cardiology, and telecardiology now at the Massachusetts General Hospital. My subspecialty is adults with congenital heart disease. And I started doing telecardiology back in 2013 because I took care of younger patients who were very medicalized, chronic disease, and often lived and came from far away. It was a natural for my patient population, myself, to want to do it. But I will tell you that it was quite a challenge to continue to try to get other people to adopt innovation at a time when there really wasn't a clear pathway for it. And so COVID, you know, one of the few silver linings of COVID was this need for institutions like our own and many others to adopt virtual medicine and to determine not only the technology needed, but most importantly, the workflows. And so I guess that is one thing that I will say is, you know, I have always been interested in innovation. I am an advisor for several different companies that, you know, do a variety of cardiac related testing. But actually getting providers to adopt technology, I think, has been perhaps the greatest challenge. And it really comes down to workflows. And so this is when Ria was presenting earlier, you know, one of my questions to her is, can we provide that workflow for people who are interested in adopting your technology? And I think it's something for all innovation women, men and women, but all people to think about is how will someone actually adopt and implement, and why will they do that? And if you can get it why the clinician would do it, then you will have perhaps one of the most successful attempts. And I say that having been taught myself that if the C-suite buys in, you're good to go. And I can tell you the number of times the C-suite has bought in and things have failed because the boots on the ground did not see the value the C-suite saw, or felt forced into new technology because of it. So I think it's just very important to think about that. Other things, just because we ended on this gender equity in pay concept, I will tell you that I did a lot of volunteer work, and I still do a lot of volunteer work at the institution. And I love doing that, committees, and you're asked to be on them. And it was just recently that I realized that there is actually a lot of value to our time. And I have colleagues who are interventional cardiologists who, yes, create some of that 30% disparity or greater that we see in cardiology. I'm a non-invasive cardiologist, and kudos to them for doing the work. And so, you know, they're my good friends, and I don't hold that against them. I did choose a non-invasive specialty, and yet it was only in the past year that I, after becoming an associate professor, you know, realized that I could hold myself out for, yeah, if you want an hour of my time, I cost this much money. And I'll tell you, you know, those numbers were higher than I thought. I would have said $250. People said, tell them $550. And so, you know, you realize that you really are worth something. And all of a sudden people started saying, sure, for your advice, Dr. Bhatt, I'd be happy to do that. And so I think asking is really important, not just within medicine, but even for using your talents outside of the hospital or the practice that you're in. And you'll be surprised at how valuable you really are. It's like a subtle imposter syndrome that even if you don't think you have it, it's just back there and holding you back. I didn't start asking for money for my time until I became an associate professor at Harvard, which you can imagine how long that takes, because I thought that I wasn't of that value until I was associate. Who told me that? Nobody told me that, right? But I decided that. So again, happy to chat more later, but I think we were given just a few minutes to introduce ourselves. So those are a few thoughts from me.
Great, that was, thank you for sharing that, Amy. Dr. Miller, do you want to go next?
Yeah, sure thing. So thank you, Paula, for getting me in the loop on this wonderful event. It's nice to be with everybody tonight. I am a general surgeon by primary training and have worked as a general surgeon for the last 20-ish years and segued into acute care surgery. And I think probably the best single word to capture me and my experiences is just being unconventional and meeting adversity from the standpoint of, being unconventional, being a woman of color. When I decided to sort of think more about acute care surgery and the process of caring for seriously ill patients, I decided to go back to training. So as a mid-career surgeon, went back to training and did a hospice and palliative medicine fellowship, followed by an ethics fellowship, hoping to sort of integrate all of that wonderful stuff into the care of suffering surgical patients. But because of a lot of the, I'd say, adversity that I've kind of encountered, which is partially what Dr. Parangi mentioned with pay, but we know that there's a lot more to adversity in medicine and surgery than pay and equity. One of the quotes that I'm going to air for the first time in this session, which has taken me a while to have the confidence to say, because it's just difficult, is that I've made more money in employment separation agreements than some people have made working. And because of that adversity, I've founded this nonprofit foundation called physicianJustEquity, which is really designed to help people of all stripes work through workplace conflicts and do it in a way where they end up kind of, being more on top than being swept under the rug. And it's just been devastating to see so many colleagues lose their reputations and their jobs and their careers over conflicts that can really be resolved amicably. So that's a snapshot about me.
Wow, thank you so much for creating such a wonderful group, Dr. Miller. Do you want to tell us about you?
Sorry, are you saying me?
Yes, yes, yes.
Oh, sorry. Okay, this is Alexis Bailey. I'm a cardiologist at UCSF. And I'll tell a little bit about my journey and kind of weave in some innovation and some women in medicine pieces within here. So I started out as a biomedical engineer in undergraduate, which is a mostly male area, and went on to medical school also at Duke. When I was in medical school, I was on the sort of student organization, and we met in the boardroom of the medical center. And so you had on the walls all of the photos of the chairs of all of the departments at the medical school. And one day we actually had a meeting with the dean, and he walked in and he's like, well, what do you guys want from me? And we pointed out to him that on the wall in this room were the pictures of all of the leaders, and basically all but one of them were men. And there were a couple of people of color, but it was just very striking sitting in that room every time we had one of these meetings. And he looked around the room, and you could tell by the look on his face, he had never thought about it before. Or at least it seemed to me that he had never thought about it before. And so I think it points to the importance of pointing this out to leaders, because it's I think a lot of times they're not doing it on purpose. They're just so used to not having to think about it and going about their own way, that it's important to point it out when you see it. And then I went on to do a cardiology fellowship, and after cardiology fellowship I got a faculty job, had a grant, was doing well, went in, tried to negotiate for my salary, and was in a place where there was some salary transparency. And I pointed out that I was getting offered far less than other people, and was told too bad. And they ended up giving me an extra like $10,000 or something. The next year, I went to the VA hospital, so I was interested to see that data, VA hospital in Seattle, and literally my salary doubled. And so, you know, there can be like powerful differences. You know, it's not like I acquired new skills, you know, in that year that were so important that my salary should double, but it did. And then when I was at the VA, I actually had a really powerful opportunity to start working on the VA's national program for developing mobile applications. And the project I worked on was developing a mobile application for this program called Cardiac Rehabilitation. And so was able to kind of flex my engineering and innovation skills while working as a physician, and was really happy to have that opportunity, and did that for several years. And then I got recruited to go work for Apple. And so I worked for Apple for 1.5 years on their heart features like ECG app and irregular rhythm notification. I helped work on the conclusion of the Apple Heart Study, and I helped Apple launch their research app and help Apple launch a study called the Apple Heart Movement Study. But ultimately I decided that I belonged back in academic medicine, and so I was happy to come back to UCSF at the beginning of this year. And I'm starting to sort of rebuild my research program and get involved in a bunch of digital health projects, including bringing digital health and innovative delivery models to cardiac rehab at UCSF. And now that COVID has hit sort of to the whole country, and not so much to the whole world because they were kind of already doing it, but helping to bring these innovative delivery models to cardiac rehab care in the US. And I'm really excited to be here. This is a great forum, and glad that you invited me to speak.
It's terrific. That's really terrific. I mean, all the panelists, I mean, everyone's coming from different aspects of medicine. I wanted to throw this out there in terms of, you know, let's talk about some of the challenges. You know, Alexis, you're talking about how, you know, all the research you're doing, and now COVID has hit. What is it like in a laboratory right now? There was a recent article about women aren't publishing any papers, strangely enough, in the last 6 months, maybe because they've shifted their responsibilities to home and unable to continue their research. I wonder if some of the researchers in our group can speak to that, what you think is going on in terms of the research world.
Yeah, so I'm in the Department of Epidemiology and Biostatistics at UCSF, and I will have to say I think we have fantastic leadership. We have a female leader, actually. And people have been really upfront about discussing all of these challenges that we have, but there's a lot of fear kind of amongst the women, and especially the early career women, about this time, because they're having to take care of their kids, they're having to educate their kids and be their kids' part-time teacher, and they're still expected to write papers and submit grants and, you know, go to meetings and help out on committees. And so I think it's putting a lot of mental stress, but I think there's also a lot of worry about the impact that this will have on career, both in the short and long term. I personally have been able to get through this time only by paying lots of money for childcare. And I'm very thankful that I have the money to be able to do that, but I don't know how I would have done it without that.
Very good.